All right, guys, welcome back. We're talking about abdominal trauma. This is part 2 of the video, and we're going to start talking about how we are going to assess and treat these folks. And the good news is, again, a lot of these things are going to be repetitive, but this is a reminder, again, scene size up. Just make sure it's safe to be there. Make sure the person that did the high-velocity penetrating injury is not there still. Determine the number of patients, okay? And integrate with the incident oversight. Again, 30% of patients with serious abdominal injuries have no specific signs or symptoms. These guys are going to be the sneaky ones, okay? These are the ones that are walking around saying that they're okay, and next thing you know, they're laying off to the side, about to die on you, okay? Usually, again, less life-threatening and more painful injuries are overshadowed with signs and symptoms of abdominal pain, okay? So again, and the problem is that the more stuff that leaks in there, the more problems that they're going to have. All right. Again, if the patient's it might be unreliable due to the owning effects of the alcohol, drug ingestion, head injury, or shock. Okay. And if they have blunt trauma, look at the strength and direction of the forces. If it's penetrating trauma, I want to know what did it, how did it work, how did it happen. Okay. And make sure that you got seat belts. So this is a good example of when the seat belt goes across. Ow. Yeah, this is something that is actually rather common, but again, it can damage underlying structures. Okay, the good news is they didn't go out and bust in their head or bust in their chest area. Bad news is now we've got some abdominal bruising and possibly underlying structures that have been damaged. Okay, if it's a vehicle crash, determine your impact velocity and again the distance the patient might have been thrown. Again, if it's penetrating trauma, we really need to know what did it. And where it went in, where it went out, the size, again, the size of the knife, the size of the arrow, the size of the gun, what exactly was fired, the angles at which they were fired. That's all part of the kinematics of that blast, and it helps us to indicate where we can find injuries, okay? ABCs, again, make sure you secure those, level of orientation. People that are on alcohol, drugs, head injury, shock, not really good, reliable sources of information. Keep that in mind as you begin to treat these folks. Suspect hypovolemia, especially for an abdominal injury. Expect their pressures to be low, okay? Limited chest irritation. Matter of fact, one of the common things you guys get is you get a head injury, but yet their blood pressure's in the tank, and they're all acting crazy and stupid, and then finally you get down to checking the flanks and you notice these 2 huge bruises on the back where their kidneys are bleeding out, okay? So again, you got to do a good rapid assessment. And by the way, here's the good news. Even an unconscious patient, you push down on the abdomen that's got blood in it, ow! They're not going to go ow, but you're going to feel the rigidity, you're going to feel the warmth, okay? So you got to assess. Okay? Look for the erythema or minor abrasions. Again, expect damage to the underlying structures, okay? Examine the surfaces and the flanks to gently log roll the patient to examine things. And by the way, that discoloration of the flanks, known as gray Turner's sign. We had Kerr's sign last time. That's the left shoulder. This is a gray Turner sign. Usually a damage to the kidney injuries, okay? The abdominal flanks, all right? Ow, okay? And if you see frank black or blue discoloration, again, suspect early injury or some sort of pathology there, okay? Assess the abdomen for its general shape and size and if it's distended, okay? And then palpate. Usually we start in the area we don't think is problematic and work to where we think the problem is. Reason is, what happens when you touch somebody who's awake and alert and you touch the area that's you think is damaged? Yeah, good chance of you touching their abdomen later on. It's probably somewhere between 2 and 3%, okay? Make sure, again, check for entrance wounds. If it's a penetrating injury, I would also check for the exit wound. Find out where that bullet, if it's a bullet or a knife wound, did it go all the way through? Again, and then the exits are blown out in nature. These are usually more serious. Wound projectiles can be very small, but remember that they've got that cavitation wave. So all of those lovely hollow organs that are in our abdomen and that cavitation wave and all that damage that it does from the energy transfer. Keep those in mind. Oh, bullet kind of small coming in and kind of small going out. Yeah, we're good. Nope, we're not. So again, ultrasound, that will allow us to do, hopefully, I'm hoping before your guys' career is done, that ultrasound becomes a little bit more mainstream. But you can identify pooling blood in the abdomen, and it's a wonderful, great, awesome tool to do that, okay? By the way, it can identify broken bones, too. Just I'm going to throw that out there. Characteristics of pain, abdominal sensation. You need to ask them when they drank it and gather a baseline set of vital signs. And again, serious internal trauma occurs with few overt signs or symptoms. And I truly mean this next statement. I would much rather you guys call the trauma alert and think that you need a surgeon and don't, than to not call it and end up that they do need it, okay? Error on the side of caution. Remember, they expect a 25% over triage rate. It's okay to be part of that 25%, all right? But again, if you've done a good thorough assessment, you should probably already know where you stand with the patient. Again, if you've got pregnant patients, remember they can lose 30% of their blood before they start showing signs of hypovolemia, okay? So watch for the earliest signs of shock: tachycardia, respiratory rate, agitation. Start looking for those things, okay? Make sure that if you do have a pregnant patient, lay them on their side a little bit. Doesn't matter left or right. We usually lay them on the left because it's just easier. But we don't want to depress the vena cava because that inhibits return to the heart. Again, Abruptio placenta, again, serious markers. It requires urgent transportation. We got to get these folks to the hospital. If they've had a uterine palpation and it feels asymmetrical, could be a sign of uterine rupture, okay? Alert the emergency department well in advance, and please, hopefully, you can take them to someplace that's got a trauma center. All right, again, reassess. If I've got an abdominal, it's every 5 minutes, okay? And the reason is because if I've got a sneaky one that's continuing to bleed and we're not seeing too many overt signs, the vital sign changes might be the only way that I actually catch it, okay? And we don't want to catch it too late, all right? So if you take it in 5 minutes, and 5 minutes later you're seeing the heart rate going up, the blood pressure starting to decrease a little bit, the heart rate goes up again. Look at those trends in the vital signs. Again, and then start refeeling that abdomen, okay? Be ready to take care of those sneaky ones, okay? Remember, proper positioning, general shock care, fluid resuscitation as needed. Remember, don't turn their blood into Kool-Aid. Again, keep their pressure at a 90, just above 90 systolic is fine. Remember, if we give them too much fluid, their blood pressure will go up, and if they've got a leak down there, it's going to bleed faster. Let's not do that, okay? Again, hypothermia, special consideration with pediatric patients, so keep them warm. By the way, any of your trauma patients, you should keep warm, okay? Again, it just helps things go along. If they got an impaled object, make sure that you keep the object from moving, and you don't want to remove it. And again, care for penetrating wounds is just like involved in the abdominal or thoracic cavities. Seal the wound with occlusive dressing taped on 3 sides to permit, again, if you think that it's a pneumothorax type situation, okay, especially if it's close to the abdomen. Yeah, you can get that to happen. Again, left lateral recumbent for your pregnant patients, tilt it 10 to 15 degrees. And again, supply supplemental oxygen and aggressive airway care as needed. Again, make sure with your pregnant females, high index of suspicion for bleeding. Uterine rupture and abruptio placenta happens way too often with our abdominal traumas, okay? Especially with our pregnant females, okay? All right, lots of stuff in the abdominal cavity. Make sure you know your structures. And again, make sure you read up and that you know those things, because I'm pretty sure there's going to be questions on it, okay? You got to know that information. All right, that's enough for today. We'll talk to you on the next one.